Good afternoon, or rather I should say great afternoon, because as all of you know, we have a wonderful opportunity to hear a distinguished speaker. My name is Phil Hartman. I have the honor of serving as the Dean of the College of Science and Engineering, and I want to be as brief as possible so that we can hear Dr. Farmer for as long as possible. I do want to acknowledge that his trip was made possible in part through funding through the Ida and Cecil Green Chair Fellowship that we have at TCU, as well as our Discovering Global Citizenship program. I also need to give a special thanks to a 12-member committee who really orchestrated all of the events that have occurred on campus, including this afternoon's event. In particularly, I want to single out Margaret Kelly, James English, and Clark Jones, who were absolutely superb and yeoman in their efforts. And also, I'd like to acknowledge Rick Bunnell, who received some training at TCU and went on to become a physician, and he's the one that made the initial connection that has permitted this opportunity. A few housekeeping functions. One is we are on a very tight timeline. I apologize for the late start, but we are going to whisk Dr. Farmer off the stage at 10 till 3 because we have an opportunity for him to be interviewed with Chris Boyd on our local NPR affiliate. So we will be very hard in our set. 2 is make sure that your cell phones are off, which is something that I failed to do earlier in the day and was appropriately chastised for. 3 is students who are in attendance, make sure you also swipe out as well as fill out the post-event survey. So as I mentioned, this is a culmination of a week-long series of events dealing with various aspects of global health. We have been fortunate and indeed I would say blessed on the campus to have 13 healthcare providers who have shared with us in a variety of formats, in classrooms, in lecture halls, in other contexts, their experiences, and the students, the faculty, the staff, and I have been truly enriched by that. It's appropriate, I think, that Dr. Farmer be introduced this afternoon by Dr. Chris Carpenter. Chris is an extremely modest individual. Yesterday when I showed him my introduction, he said, please cut all of that stuff out so that we can hear more of Dr. Farmer. So I will just tell you very briefly that Chris is currently an associate professor of pediatrics at the University of California, San Francisco. He is a former physician in Partners in Health who has done extensive global medicine, and he's also a wonderful individual. Chris.
Thank you, Dean Hartman. I first learned about our speaker today more than 20 years ago, when I studied about his dedication to social justice for the world's poorest people and his founding of Partners in Health. I then followed his career as he helped revolutionize the treatment of multi-drug resistant tuberculosis in the developing world and change the way we view and treat HIV in the under-resourced setting. Years later, while I was working in the Congo, I saw him on television advocating the international community to do more for the poor. It was then that I realized that I wanted to join Partners in Health and see firsthand true patient advocacy in action. Soon after I joined the Partners in Health Harvard Global Health Initiative in 2011, I arrived in Haiti. While waiting in line at a local food stand, I felt a hand on my shoulder. I turned around to a smiling face and he said, "Hi, I'm Paul. I'd like to welcome you to Haiti." As usual, he exuded a warm, humble, and unassuming nature. Today, I'm honored to present Dr. Paul Farmer. Paul is a university professor at Harvard, the chair of the Department of Global Health and Social Medicine at Harvard Medical School, a prolific author, an infectious disease doctor, an anthropologist, and a United Nations Special Advisor. And for me, he was my inspiration to choose a career in medicine and global health. So please, everybody, warmly welcome Dr. Paul Farmer.
you could have put a sign that said, "Please mind the step." I have enough trouble with arenas. They cause intense anxiety in me. How would you like to speak in an arena? Unless you're like an egomaniac or a rock star and have some legitimate claim to be up here, you shouldn't want to do this. But I have my own little PTSD stories. I come from a large, physically large and athletic family. And, well, just to give my youngest brother, for example, was a professional wrestler on television for 10 years. You don't believe it? Look it up. The Haitians, Chris, they look at us and they say, same mother, same father? And he's the smallest of my brothers. So, needless to say, arenas, basketball, football, baseball, all these things caused intense displeasure. On the other hand, I can tell you the Latin name of the horned frog. Because while they were off playing sports, I was the head of the herpetology club. That's true. And my first meeting, I was the president. My mother made Rice Krispie squares. No one came. No one. Isn't that sad? All this leads me to say, thank you, TCU, for having me. That was a pretty good opening, yes. I had such a great day today, especially with the students. Not to disrespect the faculty and administration. Who, by the way, you have a dean who's like really meticulously on schedule all the time. That's how they do it. That's how they roll here. And I would also like to say, in addition to thank you, and did it really have to be an arena? I think, Chris, that we haven't yet revolutionized the care of drug-resistant TB. And that's a problem, one that has been very much on my mind. I came here from Liberia and just saw someone I very much admire who has worked in Liberia, via Bombay, and in both those places, Liberia and India, urban India, I just saw so many patients. So many patients who are sick from drug-resistant TB, kind of exactly as predicted, and it is still a problem which needs the attention, not just of doctors who can figure out the antibiotics. I think we did get that right, but people from a much broader segment of society. That means all of you, particularly students. And I'm not saying that just because I'm in a great liberal arts institution, but because really I think that's where we're going to make the most progress, is when we engage everyone, not just self-identified experts, in addressing these problems. And Ebola is the same story. It's a story of a much broader set of problems than a viral disease that's transmitted in a fairly restricted way. And I'm going to just use this as an example to think back about history, about inequality, about what it's like to live in a world where some people get to go to a great place like TCU and other people are shut out from modernity altogether. And that's true whether it's in health or education. Now, these are not just problems that are far away. All day long, meeting with students, faculty, administrators, we've been insisting that global health doesn't mean somewhere far away. Fort Worth is on the globe, Dallas is on the globe, Waco's on the globe. We're sitting here on a globe that's divided largely into nation states, but that's really fairly recent history. And if you want to understand the part of West Africa that we just came from, my colleague and I, you really need to know something about history, and you can't answer as a question, which would strike many of us as pertinent. Why, for example, did this big urban epidemic of Ebola, perhaps the first one, and I'll go back to why I say perhaps, why did it happen there? Why West Africa? And why did it spread really only in West Africa? Liberia, Sierra Leone, Liberia, only in a part of it. Yes, there were secondary cases here in this state, for example. There were secondary cases in Europe, there were secondary cases in Nigeria, a couple in Senegal, Mali. But think of it, 99% of all the cases were in those three countries. And that's one of the questions I would like to answer or address. Now, PTSD being accentuated. There. Is there a map here? Thank you. The students like me, you know. I don't think they're waiting for me to fail. Are you? Don't make me call you guys out by name. So, I'm not going to go on this grand disquisition, but this relationship, again, as I said, one of the American physicians who was taking care of people sick with Ebola is here tonight. And our countries, this part of the world, the United States, have been connected for a long time. That, you don't need a history degree to understand that, right? And this triangle was traced a long time ago. People will argue, but anyway, sometime probably in the 15th century, it was already getting to be a well-worn group. It's worth knowing that. And one of the reasons I think about it a lot is really around the standards of care. And although most people here are not physicians or nurses, who, by the way, get ready, you're getting your medical school soon, we should know, just as a point of basic literacy about some of the history. I think Haitians, and I've worked in Haiti for 35 years, and Chris will tell you that they're often referring to history. I had a similar experience in West Africa, which I don't know well yet. People are familiar with their history where sometimes we get to forget it. And that's not a good idea, especially if we're thinking of global health as something other than far away. There are health disparities here. Some of you have focused on them, some of you will focus on them. It doesn't mean you're going to go into medicine or nursing, but you'll focus on them in one way or the other. And that my argument here is everybody should be thinking about health disparities. Because health disparities are related to educational disparities. And these two images are just, this is a beautiful campus, by the way. You do understand, right, how beautiful it is? Nodding, yes? The other campus is West Africa's oldest institution of higher learning. It's in the country neighboring Liberia, Sierra Leone. It's called Bay College. It's an interesting story of how it ended up in Sierra Leone. It has to do with abolitionists who founded, there's a hint, it's called Freetown, the capital of Sierra Leone. And it was an abolitionist outpost in a slave trading area and in the middle of slave trading empires, right? That's the triangle we're talking about. Again, Haitians will tell you a story, chapter and verse. But for a bay, and some would argue that a couple of other places, particularly one next door, Monrovia, right, which would become the capital of Liberia, was also an abolitionist outpost, founded by free people of color, came from the United States. Most of the free people of color and former slaves who went to found the British colony of Freetown were also from the Americas, right? They got chased north during the American Revolution along with British forces. And the other ones went directly, often from Baltimore, across to found these other abolition outposts. Now this all got forgotten after the American Civil War, so about the time TCU is founded. This history of abolitionist outposts and the idea of free people of color governing themselves was forgotten. It was an experiment that went badly, that's true, but that doesn't mean it wasn't a good idea. And again, if you want to understand these very modern questions, why these three countries and no others? Why is a colleague here with us today, a practicing physician, medical educator, whereas many of our colleagues in Liberia and Sierra Leone did not survive that same disease. Now, for the epidemiologists, the physicians, the health professionals, the nurses, the professors here, you already know all about case fatality. I'm arguing that we should all know what that means. Why should we look at case fatality? Well, it's differential mortality, right? Differential how? If people the same age, let's say, if you're controlling for age, get the same illness, and the outcomes are so different, you want to know why. And if you don't want to know why, you can bet a lot of other people are going to fill in the blanks with all kinds of ideas, many of them cockamamie. That's not a word you use very much. Many of them are just nuts. Right? Reliable every time. You get a new disease like HIV disease, AIDS, you have Africans, and again, that's a big continent. That was an indirect joke, failed. The big continent of Africa, case fatality rate is what there? And it's different in another place. In one city or one part of a city, New York City, Baltimore, you see radically different outcomes among those infected. And how do you address that? Well, in the United States, amazingly, we actually made some progress, and we shouldn't forget it. And that was even without a sound medical system, that is, when I say sound, able to reach those in greatest need with a safety net. Even without that, or with a very patchwork kind of safety net, once therapy came along for that disease, AIDS, people got better. People from all over. Just remember, this was the leading infectious killer of young adults in the world. Unknown when I started medical school 30-something years ago, but by the time I graduated from medical school, Boston's teaching hospitals were full of young people, men and women, dying of AIDS. And by the time I finished my training in infectious disease, they went home. They stopped dying. It's a pretty wonderful story, right? And you saw, if you looked at national data, again, in spite of all of our deficiencies, you saw a radical drop in mortality in 1995 and 1996. So that was a big moment. Great time to be training as an infectious disease doctor before you start, you see all these people suffering, and then by the time you're done, you have a therapy that works to suppress the disease. Surely that was about the most remarkable thing that happened during my long medical training, was the rise of HIV as a pathogen, and then followed by the basic science research that was required to understand pathophysiology, immunology, and the medications. Now, why is that relevant to people who are not in medicine? Well, access differential mortality persisted after 1996. So we saw overall improvements, but if you look, as one should, along lines of gender, insurance status, race, particularly those three, there were very significant differences in risk of acquiring that infection, but also risk of poor outcomes. And this was seen even before therapy was developed. So this wind-up is to say, Ebola may seem to most of you, except those touched directly, as a far-off problem. And it is. It is a far-off problem. It's not something that you're likely to see very often unless you go somewhere where it wouldn't be a far-off problem. But that doesn't mean it's not important, because it's clear that all of us have a stake in thinking about health equity. Now, some of us do that because you're going to be talking about security, a sort of security paradigm. I don't have a big beef with that, and maybe we'll have a chance to talk about that in the Q&A. But it's not the only way to see it. Human security could be related to our connections, one to the other. And indeed, that's certainly what inspired the physician who's here today to work in Monrovia, or work in Liberia. This is not gee, I want to work there so I can protect the United States from, or Europe from a pathogen. I want to work there because I think everybody's important in the eyes of God. That's a sounder reason, but there are many. Now, just a little bit of an overview, and I didn't know that Dr. Brantley would be here, so he probably knows 10 times more about this than I do. The stories of these, the eruption of these viruses has been, first of all, I'm going to talk about two. These are the first two in this class. Notice I refrained from using the genus name of the horned frog. And I'm going to try to refrain from using genus names or species name anyway. Well, let's just say two viruses, one called Marburg, the other Ebola. The story of their so-called discovery is really about connection, not disconnection. Marburg sounds like a German city, right? It is. It was discovered because of African monkeys, and I believe they were green monkeys from Uganda, were being sent to Marburg, Germany, via London, for what? Not for research, but actually to make polio vaccines. Right? And what happened then in 1960 kind of told you everything you need to know about how it was spread and why risk was different and why risk of dying was different between different people afflicted with the same infection. So you following me? The Marburg story, 1967, it's all written right in there. So the connection was clear, right? The connection between some place in Africa, again, probably Uganda in this instance, and cities in Europe. Because it went from Marburg to Hamburg to Belgrade in Yugoslavia. And who does Ebola afflict? What kind of transmission? You may have heard about bushmeat. It doesn't have anything to do with bushmeat. You've heard of strange, exotic funerary rituals. I have a PhD in anthropology, so I'm supposed to say stuff like that. It doesn't have anything to do with that, right? The introduction of one species from an animal to human, that's true, right? That's a zoonosis. But once it gets into the human family, how's it spread? I'm going to say one word for those who've been looking at the subtitle. It's a caregiver's disease. So Ebola infects people who care about other people. Now you can do that professionally, nurse being the apex, the height of the medical profession broadly conceived. But doctors can be caregivers too, I'm glad to say. And nurses, but most caregiving occurs where? And I would ask the students to think, where does most caregiving occur? Yeah, the family, right? So most caregivers are your family members. It happens to be highly gendered, right? It's mom, it's your aunt, it's your granny, it's your daughter. But there's an exception in West Africa, and that's the final act of caregiving, in essence, when caregiving fails. Any good Catholic can tell you that the final act of caregiving is bury the dead. It seemed very strange to hear that as a kid. You just don't think of that. But bury the dead, you think of it a lot more when you're in places like the Congo or Haiti or Liberia, and there's a lot more dead. That's the story of Marburg. The caregivers of the monkeys were, of course, people working in a lab. And some of you here work in labs. Somebody's got to take the animal colonies through using. I happen to do that at Duke University as an undergraduate. My first job, taking care of bats. Who knew I would end up being interested in Ebola? Bats are kind of nasty. And that's who got sick. And who took care of the sickened lab people? Nurses. That's who got sick the first time around. But not so many of them got sick because they had the staff, stuff, space, and systems, even in Central Europe or Eastern, Germany is West Europe, I guess, but they had the staff, stuff, space, and systems, even in 1967. They didn't know what was going on. They had no idea what was causing these fever and killing some people. But they thought, what are the symptoms? nausea, vomiting, diarrhea, abdominal pain, fever. And what happens when you have those? You lose fluids and electrolytes. So what do? Replace them. That's what happened. About 20%, a little bit more maybe, of those afflicted perished. Right? That's pretty high to me. In fact, horrific. 20% case fatality rate. But then wait till you follow the virus back to Africa, where case fatality rate is routinely between 90 and 100%. Don't forget we're talking about Marburg, and we don't even have to talk about Ebola because it's the same story. It's transmitted in a very similar, same way through caregiving. High case fatality among those who don't receive adequate care, and among some who do, right? And fortunately for many of my American and European colleagues who got ill, case fatality very low when you do receive good care. Now, this pictures of the nuns here. I'm just going to say that the only difference with Ebola is that it didn't have to get to Europe to be discovered because it afflicted Europeans in the Congo. And these were happening to Belgian missionaries running a mission hospital. And the same story as today, as 2013, is effective caregivers. Right? And in this particular example, which is quite tragic, the caregivers amplified the epidemic of this unknown zoonosis through what are called nosocomial transmission, right? They reuse needles. That's a very complicated story, well worth knowing, but it's not substantially different from what was described for Marburg. In the years since then, 25 times we've heard this Ebola alarm sounded, and it's been the same story. Now, I did not know, when I first went to this part of West Africa, which I'm going to call Upper West Africa, I didn't really know anything about the data on Marburg. A little bit, maybe. I mean, I did put Ebola on the cover of a book in 1999, a real bestseller called Infections and Inequalities. I'm sure you've all read it. The publisher said, you know, Paul, I really don't think that putting a mass grave on the cover of a book is a good marketing technique. She was right. Anyway, so Marburg, I've already mentioned this, watch case fatality rate. You can do this with any epidemic, follow pediatric leukemia. We have friends here working on insulin-dependent diabetes in Haiti, for example. Chris Carpenter is one of them. He said, case fatality is probably about 90% if you don't get the insulin right. Said, yep, exactly. So this is an important story regardless of what the disease is. I didn't really know anything about Marburg, but I did know 4 Sierra Leoneans when I first went there. The 4th one I didn't put his picture on. And this was 2014, summer 21st, June. I was going for a meeting, believe it or not, on surgical care in these poor settings. And one of them was a student of mine, Jumbotron. By there was a guy, a little roundish fellow. He was a student at the time, a physician. I'd known him for a long time. The one in the middle, a surgeon who came to the surgical meeting, and the other one, an infectious disease doctor named Umar Khan. And he was working on hemorrhagic fevers. And by November, 2 of those 3 were dead of Ebola. Right? Now that was a long time between the trip in June and coming back to work there. And during that time, again, I was thinking, I wish more citizens, not just experts, knew why some of the claims we were hearing about Ebola, that it was all about bushmeat and the strange funerary practices of the natives, and there was nothing you could do, and they were going to die anyway. I mean, how many times have you heard things like that, right? It's just, that kind of hopelessness on behalf of others, that's really something we should fight from the get-go, right? And when you're related to someone, maybe your own son or sister who gets sick, you don't feel that way at all about saying, well, you know, everyone's going to die. of who gets sick. Not true at all. Right? And that fight is really a fight, not about a specific disease or to contain it, but about the fight for equity. And as I said, global health doesn't mean far away. It means disparities on the globe. And this was a tough time because if people are convinced that it's far away and the only way to garner interest is if someone you knew were afflicted or if it spread into your country, that's not a robust way of thinking, how can we plan to prevent these problems and how can we save the lives of those once afflicted? Again, Chris mentioned AIDS, drug-resistant TB, but think about any pathology, chronic renal insufficiency, renal failure, diabetes, major complications of coronary artery disease, whatever it is that you see, you can bet that we as a species, not the horned frog. I know it's not a frog, by the way, did I say that? I was the president and sole member of the Herpetology Club. As a species, we need to be thinking of this, not deferring just to experts, right? This is everybody's business, no matter what the pathology is. And it actually is very difficult for young people, including young nursing students and medical students. We haven't been sick, and most of us have never seen a child die. Ask Chris Carpenter what it's like to go someplace where you see a lot of children die, and you're a pediatrician. Like we've been spared this. And that's a great thing, by the way, that we've never seen children. I've never seen, I work at a place called Brigham and Women's Hospital at Harvard. Women's Hospital, largest number of deliveries in New England. I've never seen a woman die in childbirth there. I know it has happened. It's a big problem in this country, and Texas is not, there's a long way to go here, but it's something you just don't see very often, but you do all the time where there isn't staff, space, and systems to make a difference. Now this is meant, believe it or not, to be uplifting. That was you're not convinced yet. Well, I'm going to make that segue to rousing cheers. What that means is this era of, just take antibiotics, the pre-antibiotic, the pre-antibiotic era, the pre-surgical era, that's behind us, right? We can see that even again when we don't have a good, careful system to roll out something good for the American people. We still see the effect. We still get it out there somehow. And I think we don't have to be proud of the patchwork nature of our system, but we should be proud of innovation, discovery, passion for health equity, which I see all the time, and certainly see at TCU. Right? We should be proud of that. Even without that, we see improvement, but there are places in the world that are still in the clinical desert. They're still in the public health desert. And this is one of them. And war-torn Afghanistan is one of them. And you know plenty of them, right? There are clinical deserts in the United States. If one part of Chicago has a higher case fatality rate, again, for serious injury, gunshot wound, trauma, and their outcomes are very different than another part of Chicago, a place like that part of Chicago that has the higher mortality is going to be called a, guess what, trauma desert. There's a trauma desert in Chicago. So these are deserts of one sort or another, food deserts in the American Southwest. Right? Are we in the American Southwest? Is this the Southwest? And they have horned toads as well, horned lizards. Some of you have been lucky enough to work with the Navajo or others along this vast part of the American Southwest, and obesity and diabetes are huge problems there, right? Different kind of diabetes than Chris and his colleagues worry about. This is adult onset diabetes, right? You can go lecture people all you want about, well, you should eat more, you should eat better, and exercise more, but if you're in a food desert, it's hard to get food. I never heard of a food desert when I was an undergraduate or a medical student, right? I never heard of a trauma desert as an undergraduate, and it took a while to figure out what it meant. That's the kind of world we're living in, and the only way to make it better is to think about those people and places left behind. And I think that's true within a country like ours and across the globe. Now, these lessons were hard learned. Here's my proof that I'm going to end on a happy note. You ready? You're saying, oh, he's not going to end on a happy note. Yes, I am. So, in between the grim part, and again, my colleague who fell ill and got better will have his reckoning of this, but I would say after my colleague, the Sierra Leonean who died on July 29th, in between then and the fall was a really long and difficult period for me in the sense that I wished we were there doing what Dr. Brantley had been doing to help out. Just one person makes no difference at all. A lone physician or a nurse makes no difference, right? You understand staff space and systems. You need hundreds of people to fight back safely in the middle of an epidemic that by then was the largest ever known, 200 new cases a week, and Freetown, which is the capital of Sierra Leone, as I said, the most Ebola-afflicted city on the face of the earth then or ever. A pretty grim time, right? The second of my Sierra Leonean colleagues that I knew died that week of first week of November. And I thought, why don't we have a party for Ebola survivors? Does that surprise you? And we even called it a party for Ebola survivors. And the Ebola survivors who I knew were like, what a great idea, let's do it. And I said, I know we should do it at the Mami Yoko Hotel. And the answer, this is a business hotel in Freetown. Some people said, they're never going to let you have a party for Ebola survivors at the Radisson. I said, oh, yeah, watch. So we had the party, and no problem. The manager said, okay, just pay for it. Where's your credit card? That's all they cared about. So it turns out there was only one survivor I didn't know. His name was Ibrahim, 27 years old at the time. He'd just gotten out of a grueling stay himself in what is called an Ebola treatment unit, which, by the way, in Atlanta, Georgia, in Emory, is an Ebola treatment unit. This is more of an Ebola non-treatment unit, isolation unit. That's Ibrahim in the checked shirt, wherever the jumbo shirt drawing is. And because I didn't know him, perhaps, I got seated next to him. And if you just imagine this setting, you're at the height of the epidemic, outside, it's dark, Ebola is raging, and that seems like a good enough term. It wasn't clear that December would be any better. And here we are with a handful of really tired nurses, doctors, and a bunch of survivors who themselves had nursed people. They were caregivers, that's all, they all got sick, every one of them. Not from eating bushmeat, not from having strange funerary rites. They had funerary rites just like we do. In fact, very similar to American funerary rites before the 20th century rise of an industry, right, to replace the family as those who buried the dead. And this kid, Ibrahim, not a kid, but he told me, I lost 22 members of my family to Ebola. And he looked at me like, what do you make of that? And I didn't know what to say. I mean, I've never seen, you don't see things like this maybe in a war, genocide, and unimaginably bad luck for a family in a tsunami or an earthquake. That's about it, right? How are you going to take out 22 members of one family? The answer is caregivers disease, right? Because family networks are how care is provided, including the last act of caregiving. So he told me, I want you to interview me. And for my friends who are anthropologists here today, did I mention I was president of the Herpetology Club? And I did a PhD in anthropology. So there, my brothers, the big athletes. They didn't get an MD and a PhD from Harvard. I'm not resentful or anything. So anyway, this stuff is so sad sometimes you have to have a little sense of humor. So Ibrahim said, I'd like you to interview me. And I had never had that happen before where someone, I mean, first of all, nobody in Haiti would say, hey, would you interview us for your next book? They should, by the way. I haven't done them wrong, but usually they don't. They know I'm a doctor, but that's about it. He said, I want you to interview me. I said, okay, I guess so. And, but he also said, I really want to help other people affected by Ebola. I'm thinking, why is he asking me? What am I, the gatekeeper of Ebola care now? I knew I was asking. He's an orphan, right? And here's, a friendly physician, not the only one, physicians and nurses who were there. They needed a new family, a lot of them. And this went on for 2 months, asking. And I was thinking, what is the worst place for a 27-year-old who's just lost his whole family to Ebola, an Ebola treatment unit? That's what I thought. But he eventually helped out with this patient named Mariachi, and there she is. And since I've already have the after picture, you can see that she survived, right? So she, I think it was Christmas Eve 2014, admitted to the place, the largest of the places, the Ebola treatment units where Partners in Hope was working in Sierra Leone, or anywhere for that matter. And she was admitted, and you get sent home when you don't, in this kind of setting, when you don't have evidence of infection in your bloodstream. It doesn't mean you don't have evidence of infection elsewhere, but it's a way to move people out. And it usually happens about 2 weeks after the height of the illness. And she indeed had negative tests and got sent immediately to a hospital that had been abandoned during the height of the epidemic. It was just being reopened. And that's where a lot of Partners in Health volunteers were, or in the Ebola treatment unit. And then she never spoke to anyone. She lost her mother, her sister, so that's her father in the background. And I was asked to see her. You remember what my specialty is, infectious disease. Why do they need infectious disease doctor if they've already figured out what her infection is? The answer was, does she have another one? Because she's not getting better. She weighs 27 pounds, she's 11 years old, that's what she looks like, right? And when we saw pictures of her from a non-clinician colleague from Partners in Health, I'm looking and I'm talking to Ibrahim. Remember, he said, I want you to interview me. So I'm interviewing him. And he's looking over my shoulder at this viewfinder, at these pictures, and went, oh my God, I told you I have to help people. I really want to help this girl. Can't I help this family? And so he went the next day, and he stuck with her and her father until she got better. But that first day, I was thinking, why is he back around Ebola patients? I mean, I knew why he was because I drove him there, but is this the right thing to do, right? And I walked in that pediatric ward, and I'm not going to forget this ever. It was a pediatric ward again. The whole place was now full of Ebola survivors. They hadn't survived Ebola, really, but they had negative blood tests. On the left, 5 beds, maybe 4 on the right, same number. And I remember every single one of the patients in that week, in any case. This is pediatrics. And on the last bed on the left was Mariachi, face against the wall. I mean, she looked like a skeleton, don't you agree? And this is probably taken a couple days later. She had a bed sore over her left hip, and she wouldn't answer. I said, Mariachi. And she didn't engage at all. And I examined her, helped put down another feeding tube, which didn't improve my reputation in her eyes, but I still didn't know, what is she thinking? And that next day, when Ibrahim came, he walked right in, went to the last bed on the left, and sat down on the bed, which already impressed me, I must say, for a 27-year-old, right? I was impressed that he was not afraid or even repulsed, because some senior clinicians we're not above everybody else. You move away from people you don't think are going to do well, that we're not supposed to, but it happens, right? I had seen experienced nurses kind of giving up on her. But he went right down and sat. And then two things happened at once. She reached up and took his sleeve and pulled herself to his ear and started to whisper something. Now remember, this is a girl that I've already said, I don't know what she's got, but I don't think she's got tuberculosis or another infection. The nurses there, some of the best ones in the hospital, saying, we think she's brain damaged. You know, she's been seen by a lot of people. And she sits right up and starts talking to Ibrahim, the hip-hop dude from the city, right? And then, all at the same time, just as I was feeling delight, another child on the right-hand side, a little girl, maybe 6, I've got to look it up. Her name was, I remember her name, not Horned Toad. She had a seizure right then and there and fell to the floor. You can imagine, if you don't have to be a pediatrician, think, oh no. First of all, why did she fall to the floor? Meaning, no guardrail. Second of all, she better not have had a seizure before this that could have been prevented the second time around she had. And third of all, and I'm embarrassed to say this, really, especially with heroic people in the audience, I thought, I don't want to pick her up. I've only got gloves on. Well, I had clothes on, but I had gloves and no proper kit. That's what I thought all at once, you know. You know, we're human. It's scary, right? Scary disease. And here you are, and you know, if you know it's transmitted through urine as well, and you know that someone who's having a seizure is going to be incontinent, and indeed she was. You know, how miserable to be a little girl and suddenly find yourself on the floor under your bed in a pediatric ward during Ebola ward. And that's what every single one of these young caregivers who were taking care of their families felt. What I felt just then, tardily. They felt frightened. They knew very well what they were. Ibrahim knew what was happening with his grandmother, his mother, his whole family. He knew, right? But they gathered their courage and gathered people up. And that's what happened. That's what we did with this girl, right? Nothing untoward came of it for me, but how many people lost their lives or got sick with this disease because they were caregivers. And then, back to case fatality, how many people died because they didn't get the care they needed once sick. We shouldn't say, okay, well, this epidemic is over. It's not the epidemic of inequality. It's not over. For the critically injured and ill, right? Someone with leukemia, someone with diabetes, you sometimes need critical care. For the critically ill, critical care. Right? And we couldn't really do that in Upper West Africa, right? Because you need the staff, space, and systems. Now, that's pretty good for a happy ending, but we could have done better after the war, right? What war? Well, the war that burned down the oldest university in West Africa. Remember I showed you the picture? You're thinking, where's the walls? Why are people squatting? Because of the war, and this was recent. This is what made this part of West Africa the clinical desert that it is. And afterwards, did we spend the money wisely to rebuild? After an earthquake, after a hurricane? Well, for those of you who are donors to Partners in Help, or other organizations working in Haiti, like Chris's and others, you want to invest in staff, space, and systems. Not just you being there, but in this case, in Haitian staff, space, and systems, in Sierra Leone, in Liberia. This is the nursing school in Port-au-Prince, the National Nursing School after the earthquake. And again, a lot of people from this university donated to earthquake relief or involved in Haiti. And this was a low point, I must say. Not being worried about a 6-year-old, I was worried about her, not fear over that is transient. But this was not transient. To see someplace you know and love destroyed like this, it's really, really hard. It's hardest of all, of course, for the Haitians, but we all lost friends in this event. But what should be done in the midst of a clinical desert, whether it's newly desertified or never watered after war, never watered. And one of the things that we were allowed to do, thanks to support, is to say, what would it be like to have a place where the critically ill and injured can go? Let's say, radically, a hospital with doctors and nurses. You know, maybe we should make it solar powered so it doesn't destroy the planet any further than we have. Maybe we should make sure it's a university hospital so that we can train Haitian nurses and doctors. And you know, that was the plan. And but it's not just a pipe dream any more than it's a pipe dream in West Africa or Afghanistan or the other places in the United States that still remain clinical deserts compared to others. It doesn't have to be that way. And I close with this beautiful picture. This is not a model. This is a real hospital functioning, and it was built thanks to largesse, largely from the United States, and from families and friends who said, we are not going to just give up and say it's not possible there. And that's what fuels me in thinking of Haiti, thinking of West Africa and working there as well. So I'm going to close and say thank you. I hope we have a chance to talk. I've saved time. I'm not rushing off. Don't let the dean rush me off. Thank you very much.
Do I leave or stay?
I know.
Can we have a couple of short questions?
There's someone down here.
Okay.
Oh.
Yeah, well, I can repeat your question if you want. There are microphones, but I can. Why don't you say it again? He's a pediatrician. He can't be blamed. Get the surgeons. Thank you, nice people who stayed, meaning you have stayed. Yeah, we can master this.